Welcome, everyone. Thank you for joining us for today's webinar, How to Use Scenarios to Simulate Invasive Care and the Management of a Ventilated Patient Due to COVID-19. This is the third webinar of a series provided by Laerdal designed to help you prepare and train for COVID-19. This is the final webinar of the series and will be about 90 minutes long. And we are going to focus on cases requiring more invasive care and the management of a ventilated patient. Please follow us online at laerdal.com or through social media to stay up to date on new resources and live webinar events. My name is Liz Bolin, and I will be your moderator today. I'm the Business Development and Brand Manager here at Ingmar Medical. And my job is to work with respiratory specialists like you to determine your goals for simulation and training and how we at Ingmar Medical may complement those goals through our simulation solutions. Before we start, let's review a few housekeeping items. To ensure a distraction-free presentation experience, audio is muted and video is off. However, we absolutely want to hear from you throughout the whole presentation, so please use the Q&A function of Zoom to ask questions. The recording will be emailed to you soon after the webinar is complete, and we will also provide links to our free scenarios and support materials as well. Please take note of the URL at the bottom of this slide. This is the COVID-19 Resource Center on Laerdal.com. You can actually navigate to this information straight from the homepage as well. Here, Laerdal is offering simulation scenarios, checklists, webinar listings and recordings, as well as resource links. And keep checking back as we will be continuously updating and adding to that library of resources. We also have a couple of ways listed here for where you can find these scenarios that will be featured in the webinar today. So you can visit laerdal.com/coronavirus. You can also find them on the Ingmar website, ingmarmed.com/COVID-19-scenarios, or you can visit scenariocloud.laerdal.com. And again, that is where you can find the links to download the scenarios and support materials you will see featured in the webinar today. And they will be emailed to you along with the link to the recording soon after the webinar is complete as well. A little bit of background on Laerdal and Ingmar Medical as a whole here. We collaborate together to provide comprehensive, realistic simulation solutions to healthcare educators. And our collaboration is so in sync because we are united in one mission together. Laerdal's mission is to help save lives by developing products, programs, and services to improve resuscitation, emergency care, patient safety, and global health. Ingmar Medical's mission is to decrease suffering and improve outcomes for patients who rely on respiratory devices and treatments. Both of these missions are dedicated to saving lives, and our missions are being fueled by the actions you are taking right now. As more and more people rely on healthcare, it is important to keep both personnel and patients safe. To help prepare your staff, that's why we're offering this set of free resources to help your teams plan and act under crisis conditions, ultimately to help save more lives. We would like to take a moment now to recognize those of you joining us today, the educators, care providers, and healthcare workers of the world that are serving on the front line of fighting COVID-19. We would like to say that we see you and we thank you. As a disclaimer, please be advised we are offering complimentary scenarios as a training resource only, and it is not meant to be a substitute for advice provided by physicians or healthcare professionals. Individuals should not use the information contained herein for diagnosing health or disease. Individuals should always follow their internal policies, procedures, and protocols. We would also like to advise you that the free scenario we will be demonstrating today is designed to train and test healthcare providers in standard precautions and infection prevention and control according to the World Health Organization interim guidelines. At this point, it would be my pleasure and honor to introduce my colleague Amy Dearsley at Laerdal. Amy, please introduce yourself and welcome.
Thanks, Liz. G'day, I'm Amy from Australia. I've worked for Laerdal for the last 8 years, helping to implement programs, both at virtual and simulation-based programs. Prior to working at Laerdal, I was a registered nurse in a critical care environment. Really excited to be part of the team that's created these scenarios, as you explained, Liz, to help people on the front line prepare for the cases that they're going to see tomorrow.
Great, thank you, Amy. And now it's my pleasure to welcome Jessica, our second speaker here. And welcome, Jessica. Please introduce yourself.
Thanks, Liz. Hi, everybody. My name is Jessica Dietz. I'm a clinical educator here at Ingmar Medical and a respiratory therapist here in the U.S. So a little bit about me. I've worked in the emergency and critical care settings for the adult population. I'm really excited to be here to share our knowledge about COVID-19 today. Okay, so why are we creating these scenarios? There's a few reasons why we've created them that we've highlighted here for you. With all of the information about COVID-19 from around the world, there are some standards that have been established. The first one being early intubation when a patient's need for oxygen increases within a short period of time. As we have seen with the progression of this virus, this can happen within 12 hours of initial supplemental need for oxygen, typically 3 to 5 days after the onset of these symptoms. Another recommendation for these patients is to prone the patients and follow a lung protective ventilation strategy. This is also known as ARDS-NET protocol. When the patients progress into severe ARDS, this is what we would do. Keep in mind, the information is constantly changing, and this could be recommended earlier in the progression of this disease as we learn more about COVID-19. Also keep in mind, with this pandemic and the increasing need of healthcare workers, healthcare providers might be working outside their normal scope of practice, which is exactly why we're presenting these scenarios today. Back to you, Amy.
Thanks, Jess. When we started out with creating these scenarios, we were very lucky to speak to some staff in China. Peter Su from Sir Runrun Hospital in China has treated over 1,000 patients at their local hospital, and he provided us similar insights. If they had their time again, early intubation, prone positioning would be things that they would have done differently had their time been changed. We've seen research articles such as this Swedish study that said in intensive care environments, when people train together in realistic environments, it helps them reflect, create openness, motivates them to learn, and create a common understanding of their team's performance. So we were grateful to be able to have the opportunity to create these scenarios behind the scenes whilst people are starting to prepare their hospital for the amount of patients they're going to receive.
So what you're seeing here is the infographic that was pulled from the Society of Critical Care Medicine. This algorithm helps with the oxygenation and ventilation management of the COVID-19 positive patients. It ranges from mild ARDS to severe, as you can see here. It also shows lower targeted tidal volume ranges, as well as other interventions to increase oxygenation due to the shunting within the pulmonary system, such as proning and trying recruitment maneuvers if they are responsive.
So as discussed earlier, we've already had a webinar series where we've created 2 scenarios. That patient in scenario number 2, Anthony DeBuzzy, is a patient that we're going to follow his treatment care through scenario 3, 4 and 5 today. Anthony DeBuzzy in scenario 2 arrives at the emergency department. But in scenario 3, he's been in the emergency department for about an hour waiting for an intensive care bed, and he's now likely going to be intubated in the scenario. Scenario 4 picks up his care when he's in the intensive care, and they're making decisions as to whether or not to paralyse and sedate this person to improve their ventilation support. And scenario 5, we thought is important to cover off how to physically prone a patient, and scenario 5 will cover this over.
So we do have some session objectives today. The first one being exploring the support materials for the Ingmar SimMan 3G immersive simulation scenarios, which Liz touched on earlier. Our second objective is to demonstrate operations of LEAP scenario file in support of peer-reviewed literature. And the third objective is the demonstration of all 3 scenarios within LEAP, the Ingmar plugin, and a ventilator, which you'll see here in a moment.
Before we jump into the scenario, I want to quickly introduce the technology that we used to run the scenario. What you see on the screen here is the ASL 5000 lung solution. This solution integrates the world's most realistic breathing simulator, the ASL 5000, with the SimMan 3G, SimMan Essential, and the new SimBaby to run scenarios with a spontaneously breathing patient supported on a real ventilator. In today's scenario, we used a SimMan 3G. And a fun fact for you, there are over 1,000 ASL 5000 users in the world out there today. It's a mix between researchers and engineers, as well as educators using it for training purposes. So how does it all work? How does the lung solution come together to give us this end result? Well, to the left of the patient is the ASL 5000, and that is what is creating our patient's respiratory mechanics based on our instruction from the LEAP software. The patient's spontaneous breaths are routed through that circuit coming from the ASL 5000, through the mannequin and out of the mannequin's mouth. So that means that the ASL 5000 is producing both inhaled and exhaled tidal volumes for our patient. So if we had the SimMan not intubated and we were simulating a spontaneously breathing patient in LEAP, and you placed your hand over the mannequin's mouth, you would actually feel that exhaled tidal volume. Then when we do intubate our patient, as you see here, and put them on a real ventilator, the ventilator is delivering support through the patient circuit, through the mannequin, through that circuit connecting to the front of the ASL 5000. So that airflow is bidirectional between the patient, the ASL 5000, and the real ventilator. In the end, that leaves us with a high-fidelity mannequin simulator, which can be intubated and placed on real ventilators for realistic hands-on training scenarios. You, as the instructor, control the patient via LEAP, and your learners will reference exactly what they would in real life: their patient, a patient monitor, and a real ventilator. All right, let's get into the scenario.
Before we get straight into the scenario, it's interesting to note, not only do we have the scenario information, we also have a scenario outline, scenario guide, and debriefing points that you might want to cover off. If you head to Scenario Cloud, you'll be able to get any of this information and use it in your place of work. These scenarios are unlocked, so they can be adjusted, changed, or altered in any way so that you can use it in your local facility. The documents for the support material are in a Word format, and this is so that you can change it to make it more realistic to your clinical guidelines or your clinical requirements in your local hospital. In the support material, there's items such as chest x-rays, blood gases, lots of other information that we're so lucky our medical team has sourced for us in order for you to be able to use them in your scenarios. This is the scenario 3 x-ray that's available. Okay, let's get into the scenarios. Scenario 1. Anthony DeBuzzy is in the emergency department. So these scenarios have all been designed to be utilised in automatic mode. Just pause there for explanation as to why we chose automatic mode. We chose to use automatic mode so that it's easier for many people to run these scenarios. We were unsure whether or not in the hospitals there would be enough people able to run the ASL 5000 intricately and also the LEAP computer. So we worked together to try and create these scenarios so that many people could run them if they needed to. That's why they're in automatic mode. If you have your scenarios, you can download them. You can put them on your desktop. You'll notice there at the moment they're on version 8. We have done another version since then. We really tried to show these to many people so that we can ensure that it meets your needs. In the scenarios, we already have a scenario outline, a learner brief and learning objectives. Let's just pause there so we can have a chance to read through it. The scenario presents with a 71-year-old male who's suspected of having COVID-19. He's already admitted to the emergency department, and because there are no intensive care beds, he's waiting in the emergency department. The participants are expected to assess, recognise the deterioration in the patient's respiratory condition and should appropriately increase ventilatory support while maintaining respiratory precautions. We've written an SBAR handover for you to utilise. You can tailor it or change it to meet your local handover style. It is now 10 a.m. in the emergency room. Situation is, your patient is Anthony DeBuzzy. He's a 71-year-old male patient presented to the emergency department 1 hour ago. Background, the patient has had non-insulin diabetes and chronic kidney disease for a number of years. Patient was reporting fever, dry cough, chest pain and respiratory difficulties on admission. Patient has been swabbed for COVID-19 and he's currently in an isolation precaution area. ICU does not have a bed. Assessment, the patient's respiratory rate appears to be increasing despite oxygen therapy. On arrival, the oxygen saturations were 91% on room air. Since that moment, he started on nasal cannula and has since been increased to 8 litres of Hudson mask oxygen at 94%. Patient has deteriorated and is now increasing his shortness of breath. Recommendations, please assess the patient and provide respiratory support as needed. We've listed some learning objectives there, such as perform a primary assessment of a patient with severe acute respiratory infection. Potentially, one of the learning objectives in this scenario could be change to non-invasive support to maximise patient effort. Express the need for intubation of a patient to stabilise their respiration. Perform the intubation of a patient in a timely manner. Connect the patient to a ventilator and contact the intensive care to discuss possible transfer into the intensive care environment. You may also want to doff your PPE after the procedure is completed. If we move further down, we've also started an equipment checklist for you. We've tried to keep the same checklist for the 3 scenario with some subtle differences between the emergency department and the intensive care. We can just keep playing now to move down the screen a little bit. And you can see there we've listed out the common equipment items that you'll need for medical supplies, props and medication. We have listed Ventolin or salbutamol or albuterol in the listing there because you may want to cover how it may not be appropriate in your clinical environment to aerosol some medication. We've listed it there just in case as expert debriefers you can bring this up after the scenario. Okay. So let's just pause there so we can have a look at the interface. We have changed the interface for those people that are quite used to looking at LEAP. We've tried to maximise the layout so that it makes it easy to run the scenarios. You will notice the events are listed in the top left-hand corner. In the middle of the screen, you will see things related to the ASL. And on the right-hand side, you'll see the standard hemodynamic monitoring. Jess, did you want to go through the next steps of the Ingmar?
Yes. So in these scenarios, we have actually built some custom models to make it as simple as possible for you to run through. To import them, you click on import and then pick the associated lung models. Choose all of the models here and import them. So you'll see you can choose them, click over, and they'll be ready to import. Then you'll just hit that bottom button where it says import models. Once they are imported, you will see them listed in your custom model library. When you are prompted during the scenario, you can simply click on the appropriate model and apply it without having to change anything. These are just built for you, ready to go. You don't have to worry about any changes to be made unless you wanted to make changes to those lung models. So once you start running these, you'll see the ASL monitor in the middle. This should give you a general idea of the flows, pressures, and volumes from the vent and the patient combined. So now we're ready to connect and play the scenario. So now it's prompting you to say that the ASL is connected and choose the appropriate lung model.
Thanks, Jess. Now in the top left-hand corner, we can apply the PPE if that's what's required at your place of work. You may choose not to apply the PPE because of it being the training environment. That's your choice. If you apply them, it ends up in the debrief file. Alternatively, you can just move straight to seeing the patient. It's reminding you again to make sure that you do choose type 1 non-invasive support. I'll just pause there to show you how we've laid out the area. On the top left-hand side, you'll see that we're moving through the patient condition from left to right at arrival, primary survey, initial treatment. As we tap off certain events, they will disappear from view to prompt the instructor to look at certain events at that particular time in the scenario. Some events will disappear as we only expect them to be pressed once. Okay, let's get started. Introduce self, identify the patient, assess level of consciousness, assess breathing, and assess pain as he had chest pain prior to the scenario. You will notice the SATs are dropping and the heart rate is increasing. As these numbers, these items will be pressed multiple times, we have listed them with zeros. Each time they are selected, such as respiratory effort, we can count that in the scenario. Other items, such as assessing the IV line or a circulation, might disappear from view. We do have x-rays if you wish to press them on the patient monitor. Just pause there. So we've got two treatment options here that are possible in the scenario, but it's really down to your own clinical judgment and clinical protocols at your particular hospital. If it's appropriate and it's part of your guidelines to apply high flow nasal oxygen, you can do this and you'll see a slight increase in the oxygen saturations and you'll see a slight decrease in the end-tidal CO2, but not enough to actually suggest that it's probably not worth intubating the patient. It still technically does really push them down the line of potential intubation. The other option is to commence non-invasive ventilation. This is interesting when we've spoken to clinicians around the world, making sure that the commencing of non-invasive ventilation in your particular environment has a closed circuit. This is really an option for you to see if people choose those options and then discuss it in the debrief and really have that moment where you practice and rehearse what it is that you're going to do before you see a number of these cases through your department. Okay, let's get going. As you can see, just a slight change in oxygen, but not enough to actually move the patient. Communicate effectively is multiple times and hopefully closed loop communication is used. We do hope that there is a moment where there is decision to intubate is discussed and the patient is informed. Just pause there. On this particular page, what we've decided to do is try and minimise the amount of moving you have to do at this critical moment in the scenario. Down the left-hand side, we have the medications that you may choose to use. The medications that you might want to use may not be listed here, and that's fine. You can customise the scenario and add the medications that you think is clinically appropriate to the scenario. These medications on the left-hand side all have a response. So as we give certain medication, they will affect the eyes, the respiratory rate, and the other hemodynamic factors. On the right-hand side, there are items that we hope will happen when it comes to intubation. There's two options at the start there, hyperventilation and non-rebreather hyperoxygenation. And this is because some people are choosing not to hyperventilate according to their guidelines and just apply a non-rebreather hyperoxygenation instead. Okay, let's see how it plays out. So in this example, we can choose propofol. If only a small dose is given, it will have a different effect. As we choose the different medications and the different choices, you will notice the ASL monitor in the middle different. So we're going to choose non-rebreather hyperoxygenation, apply cricoid pressure, advance the airway, choose the airway type. When the first ventilation is observed, a timer will appear in the debrief log to say how long it took to insert that tube. Confirm tube placement. Just pause there while Jess explains the next lung model.
So you can see here we have our initial vent settings. We are in volume control with a set rate of 20 to try to get that end tidal CO2 down. We are also targeting a volume of 420 mLs for our patient to maintain 6 mLs per kilo of ideal body weight for this particular patient. And the flow should be set around 65 liters per minute.
So you'll notice now the initial intubation is selected. We've secured the tube and we've attached the ventilator. How does that look now, Jess?
So now we can see that you can see the vent screen here, and you see here that the patient is only receiving controlled breaths. If we could just pause it, yep, due to the sedation and paralytics. If you look in the left-hand corner, there is a C, meaning that the breath is controlled by the ventilator, and you can see the total rate matches the set rate. Keep in mind that we are showing 21% here, just due to the fact that we don't have access to real oxygen at this point for the simulation.
It's worth noting on the patient monitor, when you actually see the end tidal CO2, that is a combination on the patient monitor between that by the ventilator and spontaneous breathing. So you can see now after we've intubated, that airway respiratory rate is being sensed and increases over time. On the instructor PC, when we see that in the instructor room, you'll notice it always says 0 if they're ventilated breaths. And that's because on the instructor PC, it only shows the respiratory rate of spontaneous breathing. So, as we move through the case, we might want to do another assessment. We might want to change documentation on communication. We may want to dispose of single-use equipment and doff the equipment. It's really up to the clinical team as to what they choose is most appropriate for their environment. Once the scenario is completed, We can click End Session and it will take us to the debrief file. So the debrief file, we've got different examples of the debrief file, but this is the session viewer example of the debrief file. It lists the learner brief and the learning objectives that we started with. This can remind us about where we started with the case when we start the debriefing process. We've also built in performance checklists. So you're able to, if you want to, use this as a checklist and add your own hospital logo to the top section there and do this as a checklist for many times in scenarios. The debrief information from Scenario Cloud allows you to think of potential gas questions or things that you can use to move through the scenario and the debriefing time. Okay, let's move on to scenario 2. Scenario 2 starts in the intensive care and the patient is already intubated, obviously. Once again, we browse the computer, find our appropriate scenario. We are now up to version number 9. And let's just pause it here so that we can have a look through the outline. The similar outline appears from the first scenario. It's still Anthony DeBuzzy. He's still 71. He is a suspected COVID-19 case in the emergency department. He was admitted and he's been transferred to the intensive care environment. It's now 2100 hours and we're doing handover on day 0. The situation is, patient is Anthony DeBuzzy. He's a 71-year-old male who presented to the emergency department today with severe respiratory distress due to a lung infection, which is suspected COVID-19. The patient was transferred to the intensive care unit 4 hours ago and at times has a high respiratory drive. Background, the patient has a past history of non-insulin requiring diabetes and chronic kidney disease. Assessment. We've tried to do it as a systems assessment here. Systems assessment, neurologically, the patient is awake and able to follow some commands and move his limbs. We haven't listed a sedation mils per hour because it really depends on what sedation you choose to put there. So we've just left that for clinical people to make a decision. Cardiovascularly, the patient is tachycardic, hypertensive, febrile at 39 degrees, pale at the peripheries with a CVP of 8. ETT is 7.5 and sitting 22 centimetres at the lips. Jess, did you want to talk the ventilator settings?
Yeah, thanks, Amy. So we're still in volume control, same as the last scenario. We're at a respiratory rate of 25. We are at a targeted tidal volume of 420. We've gone through many iterations, so just bear with us. And the flow should be set at 40 liters per minute with a PEEP of 10 and a flow trigger of 3.
Gastrointestinally, the nasogastric is in situ already and bowel sounds are present. IDC is in situ and he's got an 84 mils an hour running. No pressure breaks are noted and all lines are secured and new today. X-ray has been taken and is ready for analysis on the patient monitor if you so wish. Recommendations, please go and check the patient and the ventilator status. We've listed some learning objectives such as performing a primary assessment and improve ventilations by changing ventilator settings. Discuss concerns with the patient and reassess the patient. We have an equipment list listed there that is similar to the one in the emergency department scenario, just some extra things such as an art line and central line and IDC and nasogastric, things that you would expect to see on an intensive care patient. Should we pause there, Jess, and just explain the lung models?
Yeah, so what you're seeing here is the same screen we saw before, except we're in our second scenario now. So we made two particular lung models for this scenario. Type 2 patient inspiratory desynchrony, that will be our first lung model where you will see some inspiratory desynchrony on the ventilator between the patient and the vent. And then no matter what you do, you try to fix the desynchrony, it will go. You'll choose the second lung model because the patient will need to be sedated and paralyzed, and it has all the corresponding lung mechanics associated with that. So all you have to do is just click on it and apply.
So once again, now we're just starting the ASL by pressing play on the scenario, and we're ready to go. We're given again the ventilator settings. And once again, we do have the option to wash our hands, apply a long sleeve gown, apply the N95 mask, perform the seal check, and apply the goggles and gloves. This is a choice you make as clinicians as to whether or not that's appropriate in your education department. As we move to the patient, you will see this patient deteriorate over the next few minutes.
So here, if we just pause for a second, this patient is spontaneously breathing. You can see that we have high peak inspiratory pressures of 40 with a very high drive to breathe due to the hypoxemia that you would see on the ABGs within this scenario, and a total rate of 32. The top waveform is a pressure waveform. You can see that there's an inspiratory desynchrony, meaning that the vent and the patient don't match in the time it takes to inhale. This is made obvious by the large spike at the beginning of the breath. If you happen to adjust the flow or the rate, you will still see some form of desynchrony, but we do recommend that you use the settings that are recommended within the scenario. And that is just me pointing to the inspiratory desynchrony portion of the breath there, that small spike in the beginning.
Okay, great. So as we move through the start of this case, you will notice that his heart rate increases, his oxygen saturations go down. But as they start in the interim starting, it's just identifying the patient, assessing their breathing, assessing their pain, and completing a proper primary assessment. Assessment of vital signs, respiratory effort, ETT lip measurements, auscultating the lungs, ventilator parameters, loops and curves on the ventilator, auscultate the heart, arterial line assessment, central line assessment, assess the circulation and urine output. I'll just pause there. Why wouldn't we increase the PEEP there, Jess?
So increasing the PEEP would have been a natural thing that I think most clinicians would do. But since we have high peak inspiratory pressures currently, adding more PEEP to that particular patient can actually cause more trauma to the lung, especially because we look at plateau pressures, which is an inspiratory hold. It gives us a static pressure inside of the lung, and we never want to go over 30. And increasing the PEEP above what it's set at could violate those plateau pressures and just cause more damage to the patient's lungs.
Thanks, Jess. It's important to cover off communication needs, such as discussing the need to increase sedation, potentially discussing the need for paralysis, and informing the patient about the procedure. On the medication and treatment page, once again, we've got the same medications, but this time, let's choose some morphine. And midazolam. And all the medications do have a response. It does remind us that when you are comfortable as the clinicians, you can move the scenario along by changing the lung model to patient sedated and paralysed. Let's give some vecuronium now.
Okay, so now since the patient is paralyzed and sedated, we can actually reduce the trauma to the lungs as well as more closely control the ventilation and oxygenation for the patient. Once again, you'll see that C in the corner indicating that all the breaths are controlled by the ventilator. If we hit play here, you'll see that I also dropped the respiratory rate to 20. Since the patient is no longer spontaneously breathing, and we will be checking ABGs and vitals to make sure that we were making the correct choices for this particular patient based on their lab values. So you can see the peak pressures dropped from that desynchrony.
Thanks, Jess. And other medications such as anti-inflammatories might be utilised, but they don't actually move the case on at this time. You'd assume that they would do a reassessment of things such as vital signs, respiratory effort, the ventilator parameters, and how do the loops look like on the ventilator like Jess just did. Once they're comfortable that the patient is stable, and as you can see, the patient is stabilising out, they can choose to dispose of their single-use equipment, disinfect and clean the area, and remove their PPE. Once again, if they choose not to do these items, they can click End Scenario early. So as the end scenario, they can then go to the debriefing files. The debriefing files, in this case, will go through the learning objectives of the case and also the learner brief. It also allows us to look at the performance chart if that's what's required in the scenario. The performance chart might be able to give us some insights as to steps or things that are appropriate when it comes to the procedures in a hospital, and then be able to print this out and do this many times with different people. Let's move on to case number 3. Case number 3. The third case is about the act of proning a patient. You'll see here we've got the similar scenario outline. However, I'll just pause there. There's a bit of a difference with this case. Scenario outline number 3 has one main way of running, which is to prone the patient. However, there's an alternate route that has been built into the scenario. Please note that if you want to do the alternate route, you'll most likely need to have a confederate at the head. As they roll the patient over, they will actually extubate the patient. They'll need to then return the patient to the supine position and go through the process of reinserting the tube. We have built this as an alternate route, as some people we thought may want to do practicing of turning the patient on to prone for confidence building in the team, and some may want to practice the rare event of extubation when turning the patient into the prone position. Let's have a look at the learner brief now. It's now 8 o'clock. It's day 2, afternoon shift. The situation is it's Anthony DeBuzzy again. He's 71 years old and he's diagnosed with COVID-2 2 days ago. The patient was transferred from the intensive care and has been paralysed and sedated to improve ventilation. In the last hour, the patient has deteriorated. The team is considering placing the patient into a prone position. Background, the patient has a past history of non-insulin requiring diabetes and chronic kidney disease. Neurologically, the patient is sedated and was given vecuronium about an hour ago. Cardiovascularly, the patient is tachycardic, hypotensive, febrile, pale at the peripheries, and a CVP of 8. ETT should be 7.5, 22 centimetres at the leap, volume controlled, assist rate of 20, total volume target is 420, and PEEP of 10, flow trigger of 3. He does have some secretions when suctioning. Gastrointestinally, nasogastric feeding has been stopped, and on free drainage, bowel sounds are present. IDC is in situ at 40 mils an hour, and intravenous fluid is 42 mils per hour. There's no pressure breaks noted, and all lines are secured and 2 days old. Recommendations: please go and assess the patient and perform interventions to improve ventilation status. Learning objectives, once again, are about applying the PPE, if that's so desired in your scenario. Performing a primary assessment of a patient with COVID-19, realise the need to turn the patient, verify sedation and paralysis prior to changing position, delegate roles and communicate effectively as part of a team, and perform turning of a sedated paralysed patient while on a ventilator, and doff the PPE. The equipment list is not much different from case number 2. We do have lots of information listed there as part of the scenario. I'll just pause on one further note. We have checked with our biomedical team to see whether or not it is possible to prone SIMMAN 3G. If SIMMAN 3G is connected to the ASL 5000, we are not sending large amounts of air into his normal breathing lungs. It is only the spontaneous breathing bladders that are receiving any air to the chest, and all the rest of the airflow is being diverted out to the ASL. If you are going to use this scenario, they encourage you to place pillows under the chest so that you can safely prone SIMMAN 3G over onto your side. Okay, let's get started. Liz, did you want to explain Jess?
Yeah, so once again, we have our custom lung models here. So for this particular scenario, we only have one. The patient will be sedated and paralyzed and also prone. So you'll see that the patient is not making any spontaneous efforts on the ventilator.
Once again, we're going to go through the same process of connecting the ASL 5000. We have a tip sheet on this also in the scenario files. Once we are connecting and it's saying simulating, we can start through the scenario. As we move towards the patient, we have the option again to apply the PPE prior to the scenario or move directly to the patient encounter. As you can see on the hemodynamics, the patient is definitely sicker in this state. We still recommend, obviously, the same process of identifying the patient, making sure that the pain is well controlled, assessment of vital signs, respiratory effort, making sure the ETT hasn't moved, that the ventilator parameters looks consistent with what is charted, that the auscultation of heart, lungs, central line is all completed as part of the scenario. As we move through the scenario, the next will be communication. Just pause there because there's a few things with this that's pretty important. It's important to note that we do have an option there to ensure that the team has identified that there is no contraindication for proning the patient, such as chest trauma. We encourage the team to identify who is the airway lead, identifying also people in the turning position and receiving position so that we can have a smooth transition. Okay. We may also discuss the need for increasing sedation and also proning. The treatment options here, it's up to you as a clinical team as to whether or not this patient needs more medication or is already sedated and paralysed enough. That's your decision, what you choose to do there. The medications are there for you to use in the scenario if required. There is, as we discussed earlier, 2 alternate routes. One route is the normal way, which is confirmed sedation, start the turning of the patient, and then patient is turned successfully. The alternate route is that accidental extubation.
All right, so now that the patient has been sedated and paralyzed, they will be receiving all controlled breaths. The rate is set at 25 to normalize the CO2, and our peak pressures are within an acceptable range for this particular patient. Since this is right after initial proning, you won't see an immediate change in peak pressures from improvement in compliance, and you will most likely see a drop in saturations, and it will slowly increase over time. But since this is right after the proning process, this is typically what you would see.
As you can see here, we've also built the patient monitor to show the same thing. Initially, there was some spontaneous breaths and we gave some extra medication before the turning of the process. And as the patient is turned, we've added some extra artifact on the ECG leads, as you'll be most likely a lot of touching of the patient during that turning process. Okay, so once the patient is turned successfully, we can tick off that they have been turned successfully, and we will see a slight change of the patient's hemodynamics over a period of time, but they will smooth out, but we won't see that increase in ventilation straight away. After they complete the turning process, there will most likely be a reassessment of the patient to make sure that they are doing okay. There'll be communication as well as reassessment that is described to make sure that we cover off that this process is improved, just as Jess has just described. After the procedure, they can dispose of any single-use equipment, clean and disinfect, doff the PPE, and ensure safe disposal of the PPE. This time, when we go to the debrief file, we can see what it would look like if we were using sim capture instead. Down on the bottom of the screen, you'll be able to see the hemodynamics. The little blue bars are all the events that we tapped off during the scenario. And we're able to see the patient monitor and also a video screen or video capture of what's happening on the ventilator.
Thank you so much, Amy and Jessica, for sharing that insight and leading us through the demonstration of those scenarios using the ASL 5000 lung solution. We hope that through this webinar, we have provided you with information and tools you need to prepare to keep both personnel and patients safe under the current crisis conditions, ultimately helping to save more lives together. Now, with the remaining time left, we have a lot of questions that we are excited to get to. So while we prepare to go through those questions for you, please do keep submitting them through the question and answer application of Zoom. And while we are reviewing your questions, please consider taking this short survey based on your experience with us today. This feedback is really valuable to us because we want to continue providing these sessions and make sure that they are helpful for you in the future. All right, so I'm going to go to the top of the list here and start with all of these great questions. So there are quite a few questions that are Laerdal LEAP related, Amy, that you'll need to jump in here for me. And there are a couple questions just about the scenarios and the resource materials that are being given. So one of the first questions was, are there going to be any slides provided with this recording, support materials and scenarios?
So this recording will definitely be provided. We're hoping that this will be something that people will be able to play back as well as a bit of a tutorial for the different cases. There is support material, a Word document, and all the necessary information that is available on Scenario Cloud if you would like to download them. Does that answer your question, Liz?
Yeah, I think that's perfect. The next question is about these virtual simulation cases. A question comes up that says, will we be able to track our team's completion and questions? We would love to have a gamified computer game run by Laerdal with steps for PPE and intubation process with clamping and additional filters.
Yes. In previous webinars, I that there is on virtual e-simulations, and they will be provided because I did something to make sure there are COVID patients, and there will be cardiac arrest patients which can be run online without having contact with other persons face to face. So that will come. And I saw there was a question prior to that one that was on whether Laerdal would provide any simulation or any learning on PPE, personal protection equipment, how to do and sequence, how to take on and take off. And that actually also will be provided by Laerdal by an adaptive learning platform also online. So it will come. Unfortunately, it's not ready in the moment, but it will come, for sure.
Thank you. Now, regarding downloading some of these scenarios through the cloud, someone is talking about an experience where there's I guess the only way to download the scenario is through Internet Explorer. Do you guys have any experience with what kind of browsers are generally accepted for downloading the scenarios?
No, I can see that question. I'm not 100% aware of a particular browser, but I suggest we find out exactly who that person is so that we can link them up with a technical person in their country and make sure that you can get a hold of these scenarios. They are also available on the other two websites as well. So maybe if Scenario Cloud's not producing the information, maybe you could try the other two websites or contact the FSEs in your local country, because I'm sure they'd be happy to help you through that problem.
Great. Amy, will you speak to running these scenarios if someone does not have an ASL 5000 and what that may look like?
Sure. So you can use the ASL plugin in virtual mode, but you do lose some of the effects of the scenario because you're not having the ventilated breaths come through. But I would say that your website, Liz, has a lot of really great online learning packages from all the different ventilator systems from around the world. And that might also be a really good place to do some virtual ventilator training for some people. So I would definitely head out to that website as well.
Okay, and I know that you mentioned the scenario works with SimAN Essential, but did you mention that Nurse and Simulator would work as well?
So it works with SimAN Essential with the ASL lung adapter and ASL, but not at this stage with Nursing and Simulator.
The next question is, what software level or LEAP add-in should our ASL 5000 be at to optimize the use of these scenarios? LEAP version 6.3 or later is required for use with the SimMan mannequins, and LEAP version 6.7 or higher is required for use with SimBaby. And to upgrade your mannequin or your LEAP software, you can contact your Laerdal representative.
We've designed these scenarios, so we used LEAP 7 for these scenarios, but you can, as you say, use another version, definitely.
Next question is, what if participants select settings different than what the ASL 5000 expects?
I'm assuming you mean settings on the ventilator. It would react just like a patient would with the set compliance and resistance. So, you know, you can really change those settings around on the ventilator, and you would see, depending on the settings you put in there, increased peak pressures or, you know, fixing the desynchrony, whatever you're trying to create, you would see. Just think of the ASL 5000 as the lungs of the real patient, and you know, you're tweaking the vent in order to manage the mechanics of the actual patient themselves.
I think you were saying also in some of the scenarios, some people may choose to move to pressure controlled ventilation, and they can try all those things, but it won't necessarily improve the patient. That's correct, isn't it, Jess?
Yeah, and any mode of ventilation you can use with the ASL 5000. Now with that particular one we created with the inspiratory desynchrony, I did put it in pressure control, and there still was a slight desynchrony that you saw there. So you can try to fix the issue, but this particular lung model that I created has such a severe desynchrony that it's very difficult to fix, hence the need for sedation and paralyzation.
Another question here is, as we are asked to consider nurses and non-respiratory folks to manage ventilators in these situations, it would be great to consider a scenario or teaching model with scenarios to quickly provide simulation opportunities to learn ventilator basics. That's a great point. I will say that if you head over to ingmarmed.com, that's ingmarmed.com, from the homepage, you can navigate to our brand new COVID-19 knowledge base. And right from there, you can find a recording right now that's on ventilator basics, as well as or I should say specifically to supporting a patient who is diagnosed with COVID-19. So that's a great place to start there.
Yes, and there's then of course also the scenarios. There should be room for experiment and tries with the ventilator settings that are incorporated with the real life scenarios. So there you can also put in some teaching aspects, because that would be, you know, reflecting what is going on at the moment, that people without long experience, when there's shortage of people in very stressed areas like Italy or Spain, or now actually even the latest reports we get from France, you know, that people just have a crash course and then they are dumped into the setting with a COVID patient and have to deal with a ventilator. So that will also be a good place to simulate that and use your local equipment so it resembles what you will meet in the real life setting.
We're hearing teams of people training to have people ready to act up into those positions at this stage in different countries, where they've learnt and seen some of the countries and having to do that. And really simulation offers that unique opportunity to have those opportunities to practice before they are thrown into that first patient, to give them somewhat of training. And we're hoping that humbly that these scenarios might help you in those endeavours.
Will a positive COVID-19 patient be able to utilize the oxygen supplied by the ventilator even when there is scarring and other damage to the lung?
That is definitely more of a pathophysiology question about COVID-19. So, um, yes, they do use high oxygen levels in these patients because the hypoxemia is so bad from shunting issues, diffusion issues with the patients. I mean, they're still coming out with more information from autopsies and things like that in China. So it's hard to know whether there's scarring and damage with these patients as far as the information that I've read. I don't know if anyone has anything else to add to that.
Yeah, this is Lars Erik speaking. We have some experience from previous the MERS, Middle East respiratory syndrome, and the SARS back from 2003, where people to a larger degree went into this crashing, which we see now with the COVID, but it's the clinical presentations more or less the same. And it seems like it's kind of a two-step disease. You start out with a viral infection, a viral pneumonia, and normally you clear that off. But in this little percentage, it triggers a cytokine storm and inflammatory acute respiratory disease, which leads to the capillary leakage in the lung that gives you the edema. But later on, if you have had this for severe cases, we do see interstitial lung fibrosis and traction bronchiectasia. So it is expected that people will get damaged lungs further down the road, but for the fibrosis to take place, it will take at least weeks. So in the acute setting like this, it's more dealing with inflammatory exudate. It's dealing with, of course, the core pathology here, as you said, the shunt fraction, that we have acute edema coming from within inside because you have the acute capillary leakage syndrome in the lung.
Thank you. I would like to clarify something, and I'll use this question as a way to do it. So someone was asking about whether the ventilator shown in the scenario was a simulated ventilator or a real ventilator. And to be clear, again, we are using real ventilators, and you would use your real ventilators that you have in your organization for performing these simulations as well. And the follow-up question was, why are you changing the lung settings when the patient is intubated? And Jess, I'll let you speak to that, but as far as I'm aware, if anything, we would have just made the lung model to where the patient was no longer breathing anymore, and that would have been the model that we changed it to.
Yeah, I don't know. So there's, depending on how the person worded this, they could mean that the vent settings as well. We didn't really change the models a whole lot, except for really making them apneic based upon the drugs delivered to the patient. But as far as changing the settings on the ventilator, when the patient is spontaneously breathing, and we did show a desynchrony, your first step should be to try to possibly fix that desynchrony before deciding the patient is just too sick, too hypoxemic to actually let them spontaneously breathe on the ventilator. So that would be why we were changing some of the settings, like the respiratory rate, to try to match the inspiratory time to the patient on that particular model.
And Jess, what did the A mean on the ventilator? We know that the C was for the controlled breaths. What about the A?
So volume control, assist control. So A means it's assisting, that the patient's actually making an effort with the ventilator, and control means that there was no effort given or taken from the patient. So it switches back and forth based upon the effort of the patient. When they're apneic and sedated and paralyzed, they're obviously not making an effort, so it's a C. But in that inspiratory desynchrony lung model that we saw running on the ventilator, they were making an effort, causing the desynchrony. So that A is more of a indicator that the patient is taking a spontaneous breath.
In the lung model, do you click the patient type and it opens it, or do you have to import it? And I believe with these scenarios, you do have to import your lung models into Leap, which is very easy, and we're happy to show you how to do that. But once they're imported in there, they will appear in your custom library, and it's just 2 clicks on the lung model, and that will activate the patient that you would like.
And we have a support material, attached to step by step that we've designed in the support material if people want to follow that in a printed form.
Excellent, thank you. Next question, can we simulate auto PEEP with ASL 5000? Jess?
Yep, you definitely can simulate auto PEEP. Anything that, any kind of lung mechanics or recreations of issues you want to create on the vent between the patient and the vent, you can do with the ASL 5000. So creating any of those issues, you can do inspiratory holds, expiratory holds, you can create auto PEEP, a whole series of issues if you wanted to.
Amy, here's a couple questions for you. Are the scenarios able to be uploaded onto vSim?
It's a great question. I saw that one there. What I will do is I will forward that to Buffy Allen at Laerdal Medical and say that a customer has made that suggestion. But I don't know if they're able to be uploaded, but I think it's worth always thinking of how we can help customers in the future.
Great. And can you give any recommendations on proning for the Simian 3G? Head on the bed and to the side, or head off the bed?
That's another great question. When we spoke to the biomedical team about that, they definitely suggested pillows down the middle in order to increase the softness underneath where the chest is and allow the arms to fall more naturally beside the body. And when we turn the patient's head is slightly turned to the side, but not hanging off the edge of the bed, as a lot of the mechanics are in the head. So I wouldn't suggest the person having the head hanging off the end of the bed. But yeah.
Thank you. Can sedation and paralyzation monitoring be simulated? For example, use of bispectral index?
We'd love to have that, and we have put that forward, and I will put that forward again to the team to actually add that to the patient monitor. To my knowledge, the only thing at the moment on the patient monitor is Trainer 4, but we are working with the LEAP team to see if we can add BIS there.
There's some more questions about just in general, if someone does not have access to a ventilator, how to use this scenario. And I do think that the ventilator recordings from this recording that will be emailed to you is something that you could use in place of that performance, but still run the scenario within LEAP without.
Also to add to that, if you don't have any ICU ventilators or transport ventilators, I'm not sure if you're aware of this, but the Philips V60 can actually be used for invasive ventilation. Now you have to make some modifications to it and put certain settings on it. But if you have one of those available, you could still do the simulation with that particular machine.
Next question, if a learner changes the ventilator settings during the scenario and the ventilator screen is not visible or blocked, how does the instructor know what settings were changed? I would say in that sense, that's where you are relying on your learner to give you verbal cues and announcing out loud what changes they are making. Amy, go ahead.
You can have some sort of indicators based on the ASL monitor in the middle part of your LEAP screen, because if there's major changes, you will see that because it's sensing what's happening at the patient as well. And the other thing is to think about positioning maybe a camera in a view that can still capture that so that you can still see what they're changing is another way to go forward.
Yes, and again, remember the rules of crisis communication with closed loop communication and evaluation and summarizing all these principles where it is expected that you have this clear communication, so you definitely have the verbal feedback instead of just doing something in the acute setting without speaking it out loud. So that's a good opportunity to also practice communication skills.
Just browsing through the questions here and seeing what we still need to answer.
Jess, did you want to answer about the square waveform on the CO2 monitor trace? What's that reflecting to onto some of our ventilated patients?
I don't quite understand that particular question. Was it something where we switched the lung model and saw a different CO2 waveform?
Yeah, I think the CO2 waveform, from my understanding, changes based on if it's a ventilated breath or if it's a spontaneous breath. And so sometimes that can change on the waveform, but we can also adapt that as well.
That's my understanding as well.
How many people do you have participating in the scenario where the patient is placed in the proning position?
I would say it depends on local guidelines as to how many people, but I think it's actually worthwhile having that conversation at the local area because as we prone the patient, we have to do it in a way that's safe and making sure that we're not overcrowding the rooms as well. So I would suggest that maybe this is an opportunity to think, hey, how are we going to even do this if we do need to prone these patients that are coming to our hospital?
Okay. Here's a question about scenarios of an intubated COVID-19 patient who is coded. I don't believe we have that right now, but it may be something that we have in the future. Amy?
I do know that resuscitation councils, such as the Australian Resuscitation Council, has actually released specific council guidelines in relation to what to do if a COVID-19 patient does have a cardiac arrest. So I'd first suggest going through to your local guidelines because each country really has put out some interim information for anyone resuscitating someone with suspected COVID-19. But it's also a really great case that we could utilise in the future as well. Thanks for the suggestion.
Can the ASL 5000 be used in a laptop ventilator, LV 1200/portable ventilator?
Yeah, it certainly can. The ASL 5000 is compatible with any ventilator.
There's a question here about transferring the ASL 5000 settings onto the Ingmar QuickLung. You're going to be pretty limited with that. There are 3 resistances and 3 compliances with the QuickLung. And the QuickLung is also not spontaneously breathing. So you'll be a little bit limited to that, but I suppose you could try. There's a couple questions here I'm not going to be sure if our team is going to be able to answer because they are just about the COVID-19 virus in general, but I will ask them. So one is, how long are patients staying on a ventilator before starting to recover?
Here,
yeah.
Go ahead, Lars, sorry.
Yeah, we do have some experience in that, and there's quite a lot of spread. There's quite a lot of variation depending on the reason for going on the ventilator. So we really have to see what is the setup of the patient before going into mechanical ventilation. Is it because of a background disease like exacerbation of a COPD or some other disease that this puts on an extra load, or is it a previous pretty healthy person that develops SARS, this capillary leakage syndrome I alluded to previously? And of course, if we have these well-known cases, these would take the natural course of this well-known case. But if it's the SARS, we can go in to see what have been published, what have been reported previously, and that is a pretty long course on mechanical ventilation. Then again, where you can expect up to 5 to 10 days or even longer. But then again, there have been reportings of cases that just need half a day, maybe 1 day on a ventilator, and then they can get off it again and get referred out to the normal acute medical ward. So the spread is long, but if it is due to the SARS or the ARDS caused by the COVID, you should expect that it's a pretty long run you're on the ventilator in general.
Thank you. In patients who do survive COVID-19, do the lungs heal? Do we know that, or is the damage irreversible?
They heal to some extent, but the problem is that if you have had this inflammatory exudate in the lungs, you will see quite some fibrosis. And I know for Europe, and especially for Denmark, we are setting up trials at the moment to see long-term consequences. We will take people back in like 3 or 6 months when all this is over, and then we'll run them through functional tests and HRCTs and so on. So we will get a lot more knowledge about it, but from the previous epidemias from SARS and MERS, we know that unfortunately we will see respiratory disabilitation out of this, unfortunately.
Yeah, I can add to that as well. This is Thomas here. That regarding the last question again, what I see most on the literature is about 6 to 12 days of respiratory. That's sort of like a average, I guess, to answer the question.
Thank you. Amy, do these, go ahead.
I can see a question there that says, can scenarios be remotely run by instructors? And we've seen some use of that in different countries around the world from the Laerdal side. What some customers have been quite inventive with restrictions and isolation requirements. And as long as someone is at the hospital facility or the area, the training environment, if they can set up the mannequin, the instructor PC and the patient monitor, if the organisation is happy, someone can remote in and do remote desktop to the instructor PC and run it via a remote desktop from their isolation from home if they're well enough to run it. So we have seen some people around the world being quite inventive with having people being on isolation, but well enough to still participate in the healthcare environment and still needing one person in the room actively there as a debriefing, but it does mean that it's a bit easier to run. I hope that helps with that question.
Amy, do the scenarios expire for download?
Not to my knowledge. These are free scenarios, both available on Scenario Cloud and also on both websites.
Thank you. Jess, how do we check for proper seal when wearing an N95 mask?
Well, here in the US, we have OSHA standards for proper seal when you're tested. It's typically a spray that you can taste sweet. Some people just genetically cannot taste it, so they have to wear a PAPR. But that is the only way that I know that you would actually truly know if you have the proper seal on your face for an N95.
Thank you. Is there a workaround to simulate a low preset airway resistance with a scenario designed for high compliance of the respiratory system during HFJV and volume control ventilation with a decelerating waveform?
Low preset airway resistance scenario. The only way I could, it does work with a jet ventilator. That is not an issue. So you can certainly hook that up to the mannequin and the ASL. I would think that to get the expectations of your lung model, you would have to actually customize your own lung model, which the plugin comes with. The ones you saw today, I just went ahead and pre-made for this particular scenario, but you can manipulate compliance, resistance, the muscle pressure to create the spontaneous breath, and the respiratory rate.
And assuming that someone does have the ASL 5000 lung solution, how can you create desynchronies for other scenarios?
It's possible. It does take a little bit of time and effort to create the desynchronies, but through the plugin in the advanced windows, you can manipulate a single breath. So let's use the inspiratory desynchrony that I created for the scenario we saw today. So I basically made the vent a certain I time and the patient have a different I time in order to create that inspiratory desynchrony. You can do that with a cycle desynchrony, an expiratory desynchrony, any type of desynchrony you want to create. It just takes time to manipulate the numbers between the patient and the ventilator in order to obtain that particular one.
Thank you. One remaining question here is about credit hours to run and practice these kind of scenarios. I know that for these particular webinars, we didn't get any CEUs for them because it was, that kind of takes some time to get that approved, and we really wanted to get this information out here urgently to you. So that's definitely something we're considering in the future for future webinars, but right now I don't believe that there are credit hours for these scenarios. We encourage questions to keep coming in. We are down to a couple of questions here. One of them is not in English, so unfortunately I can't read it. Hopefully someone's able to translate that for me.
It looks like German.
Next question, can a test lung be used instead of SimMan 3G?
Jess, did you want to take that one?
Yeah.
So test lung connected between the ASL and the ventilator?
Yeah,
the question.
You can do that. With test lungs, unfortunately, you are extremely limited to the settings between the resistance and the compliance. And typically, most test lungs are not spontaneously breathing. So you would either have to manually make the breath happen with your hand on the test lung. And getting those repetitious desynchronies and issues that you see on the ventilator would be very difficult to do with just a test lung.
Yeah, in general, test lungs we've noticed are great, affordable tools for maybe some hands-on, quick demonstrations of a singular, particular interaction on the ventilator, maybe in a classroom setting. Whereas something that's more sophisticated, like the lung solution, is best for those structured scenario simulations that have multiple patient conditions that change over time, for example.
This is Lars Erik here, just translating the German question. It's about software, whether the user have to update the LEAP software in order to run these scenarios. Actually, that's technical. I wouldn't be able to answer that. Does anybody know that?
Yeah, LEAP software 6.3 or later is required for use with the SimMan mannequins, and if you want to use it with the SimBaby, then LEAP version 6.7 or higher is required to use this ASL 5000 lung solution. All right, and it appears that we have answered all of the questions at this point. I'll give a couple more seconds in case anyone has any final questions. But I will take this time right now just to say, from all of us at Laerdal and Ingmar Medical, thank you so much for joining us, and we appreciate you being here. Thank you and take care.